We welcome Dr. Shouvik Haldar, consultant cardiologist and electrophysiologist from the Royal Brompton and Harefield Hospitals. And Dr. Haldar is also a member of the Arrhythmia Alliance Executive Committee. Thank you so much for addressing some of the patient questions today.
Thank you very much for asking.
We'd like to focus on SVT. Could you explain what is SVT and what are the symptoms, please?
Okay, so I think it's useful to understand what the actual term means. The heart is composed of 4 chambers, 2 top chambers and 2 bottom chambers, and supraventricular tachycardia means supra, so above the ventricles, which are the bottom chambers, and tachycardia essentially means fast heart rate, which people will perceive as palpitations. So that's what the term means, supra, so it's above the ventricle rhythm disturbances. There are a number of SVTs, and the common symptoms are that patients generally get very sudden onset, fast palpitations, and they're usually episodic, so that's why sometimes the term paroxysmal is used to describe SVT, so they come and go, and they are usually discrete episodes, so sometimes lasting a few seconds, all the way to minutes and hours at times. You asked about the symptoms. Well, they can vary, but the commonest is, of course, the uncomfortable feeling of very fast heartbeat. But in addition to that, some people may feel very tired, very breathless. Some people may have chest discomfort, dizziness and lightheadedness. Those are the key symptoms that people get.
Thank you. So PSVT and SVT are actually the same thing.
They're actually the same thing, yeah. The P stands for paroxysmal, as I mentioned, and that simply means episodic, essentially.
Thank you. And what are the different types of SVT?
Okay, so there are a number of different types. I'll try and break it down into the sort of common ones and the less common ones. The commonest ones are 3 types mainly, and I'll tell you the long names, but I'll explain what they mean. The first one, which is the commonest type, is called AVNRT, standing for atrioventricular nodal reentry tachycardia. So that's a bit of a mouthful, but in essence signifies slightly...
Sorry, Shouvik, I think you'll have to repeat that. It paused. I don't know if it paused on yours, Maddie.
It didn't on mine, but you were a bit jumpy just then, Trudie, so...
All right, so okay, in that case, it must be my end. I won't interrupt her. Sorry, if you repeat.
Should we start that again, yeah?
Yeah, repeat the question, yeah. Sorry, repeat the answer, yeah.
Okay. So there are many types of SVT. There are a few that are very common, and there are some slightly less common ones. The most common ones do have long names. The first one, which is the one that is most frequently encountered in patients, is called AVNRT, and that stands for atrioventricular nodal reentry tachycardia. The next one is something called atrioventricular reciprocating tachycardia. And then the next group is a group that encompasses many subgroups called atrial tachycardia. So if I deal with those first, in essence, you have a normal pacemaker in the top right-hand corner of your heart, where electrical impulses are generated, spread throughout the top chambers, cause those chambers to contract, and then go to a middle area called an AV node, which is like the electrical junction box of the heart. And through there they pass and then go down to the bottom chambers, the ventricles, and cause your bottom ventricle chambers to contract. Now, the ones I mentioned for SVT essentially result in abnormal wiring of some of the top parts of the heart, such that you get very fast palpitations episodically. And you need a few things to happen for them to start, including some extra beats, and then perhaps some patient factors such as excess caffeine, stress, anxiety, and many other factors.
Thank you. And is IST the same as SVT?
Thank you for asking that. In essence, that's one of the ones that comes into the less common varieties of SVT. So it is a type of SVT. It is something that stands for inappropriate sinus tachycardia. So if I should explain a little bit more about this, because this is a not uncommon phenomenon. In essence, when you exercise, your heart rate goes up, as it should do, and that's called sinus tachycardia, and that's a normal phenomenon. Normally, and of course there are no absolutes in life, but most people have a heart rate between 60 and 100 beats per minute at rest. But inappropriate sinus tachycardia refers to someone who has a higher heart rate at rest, so generally above 100 beats per minute on average, and that can of course go higher when they exercise. It's a complex phenomenon, and if I'm honest, still to this day, we don't really know what causes it. But I think the key word to say here, it's benign, so it is not harmful. In a very small proportion of patients, it may damage the heart chambers. But in essence, there are a lot of things that you can do as a patient. For example, often the patient is physically deconditioned, so essentially needs to live a better lifestyle and exercise better. And of course, drugs can be used, but we tend to use them as a last resort after lifestyle modification.
That's interesting, because several of our patients have asked about treatment options. One person has very bad symptoms, but they've not been given any medication yet.
That's absolutely right. I mean, we very much try conservative measures first. And the other thing I should say here is that usually inappropriate sinus tachycardia happens in a sort of cluster of a few years and then disappears. Generally happens in younger females, but often if you can control the symptoms with conservative measures, knowing that it's not harmful, plus or minus the odd medication or regular medication if really needed, generally these phases pass. I should probably say that in the past, there were the practice of utilizing an interventional procedure called ablation to modify parts of the heart. However, those procedures have been shown to be not effective and are essentially in the latest guidelines. We are not recommended to do those going forwards.
And for some people, it's difficult when they're not permanently in SVT, trying to capture the episodes. Are there any devices, any of these mobile apps, digital technology that you would recommend for the patient to be able to capture, to help the doctor to lead to a diagnosis?
Trudie, I'm really sorry to disturb you there. It was really quite choppy and changey on your end, so I would suggest possibly trying to try and do it again.
Okay. All right.
Sorry.
No, the internet. The last couple of days, the internet's been awful.
Yeah, it was kind of, your voice was fading in and out kind of thing. It was fun, yeah.
Right, I've switched everything off. There's nothing on in the house. Okay, I'll repeat that one. For some people, it's very difficult to capture episodes of SVT and therefore be able to demonstrate to their doctor. Is there anything they can do? Any home devices, mobile, digital devices, hearing a lot about?
Absolutely. I think these devices have come into the fore for this particular problem. Essentially, it's very difficult to capture palpitations when they are episodic and also infrequent. Yet the patient gives a very good description of something that could well be, for example, SVT. So in the olden days, we used to do a number of sort of Holter monitors fitted in the hospital, could last from 24 hours through 1 week. But you can imagine if you don't have symptoms in those time periods, you don't capture them. And we used to go around in circles doing these tests. But nowadays, and I will probably flag up two of the most commonest ones. Everyone's probably all heard of the Apple Watch, and also something called the AliveCore device, both very freely available, FDA approved. These are fantastic because in essence, the patients are in charge. You can capture pretty good, what we call single lead ECGs, which are able to show you the rhythm if you are able to capture it when the SVT symptoms happen. And I can tell you from personal experience, I have utilized this pretty much up front in patients who have these devices anyway. And we have reached the diagnosis far quicker than perhaps we would have done in previous years. So these are fantastic devices. You do need a little bit of practice when obtaining them, for example, to get a good quality ECG, but that's not hard. And I think these are coming really into the fore now. Very useful.
And we have a lot of information on these various devices and patches and halters on our website. So patients could visit the website, heartrhythmalliance.org, and read a lot more about them before.
Absolutely.
And
Absolutely.
this is their doctor as well. Another patient says they have SVT and take a low dose of beta blockers. However, sometimes their symptoms are really bad. Should they be concerned?
So they shouldn't be concerned, because as a general rule of thumb, SVTs are not life-threatening. They just make you feel awful when they happen, and that is fully understandable. So the key for SVT is very much on the frequency and duration of symptoms. That's how we kind of manage our patients' decision making. So frequently we use beta blockers as a common drug. Generally what they tend to do is they reduce the number of episodes, and when they happen, reduce the duration of the episode, but they will not necessarily eliminate all episodes. So I can understand that patients may have some breakthrough symptoms. What I would say is if the trend of symptoms is getting worse and the symptoms are intrusive to their lifestyle, I would strongly recommend that they go back to their cardiologist or electrophysiologist and discuss more definitive treatments, such as catheter ablation.
Could you explain what catheter ablation is?
Of course. So as I mentioned earlier, these SVT rhythm disturbances are usually due to sort of faulty wiring in the heart. And we have a lot of experience in the electrophysiology community over the last 2 decades, if not more, of using small wires to go from the groin usually up into the heart and to find these areas of abnormal wiring. And we often apply some heat or cold energy to these areas to disrupt those wrong wirings, to correct the sort of dysfunction. And that can lead to resolution of symptoms in over 95% of the time in most SVTs with one sitting. And I should add, these procedures, although sound scary in principle, we do these as a day case often under local anesthesia, so patients are awake and it's not frightening. And we do this in controlled conditions, and patients go home the same day with very good chance of success. Some patients, about 5 to 10% of patients, may need a second procedure depending on the complexity of the rhythm disturbance. But I think it's something that we are using much more first line, and that is in accordance with recently published international guidelines as well.
Often when people hear of an operation of the heart, they think of open heart surgery, but as you said, ablation is often a day case. I think the most famous public figure was Tony Blair when he had ablation for a different arrhythmia, and he was back leading the country later that afternoon, wasn't he? So,
absolutely. Yeah, I mean, these procedures are not open heart surgery. They're what we call minimally invasive. So they're little keyhole punctures in the groin. And essentially you can generally mobilize the same day, if not at least the day after. And people are back into action, within a day or two. It's really not a problem. And the results are so good that I would recommend these procedures after discussion, of course, with your doctor, because, we can really do good treatments with good success rates.
And finally, you mentioned earlier, before drugs, before intervention, you always try to help patients manage SVT with maybe lifestyle changes. Could you expand what sort of lifestyle changes, diet, exercise, etc.? What can the SVT patients do to try to help themselves without having to have drugs or intervention?
So I think a general rule of thumb is all the things you mentioned. So it's important to have a good, healthy diet, to try and keep an eye on your weight and exercise frequently. Keep in mind things like caffeine intake, to not smoke at all if possible, and to, of course, keep an eye on alcohol intake. But even with those measures, some of the commonest SVTs may still be problematic because it's essentially a question of incorrect wiring in the heart. So you can help yourself, but still you may need medical attention in the form of either drugs or an ablation procedure.
Dr. Haldar, thank you so much for explaining SVT today and also the electrics of the heart versus the plumbing. We all think of plumbing, we don't realise that our heart is electrical as well, so it's important to be aware of our heart.
Absolutely.
Thank you.
Thank you very much.